Here we'll learn about non-neoplastic uterine and cervical pathologies. Start with some anatomical and mechanical disorders. First, indicate that pelvic organ prolapse occurs when the pelvic muscles and ligaments are too weak to hold the organs in place, and the pelvic organs descend, bulging into the vaginal wall. In our diagram, we show anterior prolapse via the urinary bladder, midline prolapse via the uterus, and posterior prolapse via the colon. The patient may experience some or all of these variations. Prolapse can happen at any age, but it's most common in patients with the following risk factors: being 70 years or older, high parity with vaginal delivery, connective tissue disorders, and chronic constipation. Pelvic organ prolapse is quite common and to a certain extent non-pathological. It becomes problematic when patients experience sexual, urinary, or defecatory dysfunction. In mild cases, PCARs can be beneficial or corrective surgery can be performed. Next, show that uterine rupture is most often a complication of late-term pregnancy and labor, in which all three layers of the uterus split open. Uterine dehiscence is the term we use when one or two layers of the uterus rupture. The most common risk factor is previous cesarean delivery, which leaves scars that are vulnerable to tears. Other risk factors include exposure to uterotonic drugs, multiple gestation, advanced maternal age, shorter pregnancy intervals, and trauma. Some genetic disorders, such as Ehlers-Danlos and Loeys-Dietz syndrome, also predispose patients to uterine rupture. Uterine rupture leads to hemorrhage and fetal distress, so emergency cesarean section and uterine repair are crucial. Next, indicate that adnexal torsion refers to torsion of the ovary and or the uterine tube. Unfortunately, the symptoms of adnexal torsion are often nonspecific, and diagnosis and treatment are often delayed. However, torsion requires emergency surgery to avoid necrosis and permanent damage. Thus, we need to have a high index of suspicion for this diagnosis, particularly in patients with acute pain and nausea and vomiting. On imaging, we'll see ovarian edema from impaired vascular flow, a so-called whirlpool sign, characterized by a para-ovarian structure with concentric rings and abnormal positioning of the ovary itself. Risk factors include hydrosalpinx, ectopic pregnancy, paratubal cysts, ovarian masses, and other extrinsic lesions that pull the tubes out of place. Next, let's turn our attention to the uterus. We'll start with endometrial tissue overgrowth. Indicate that in endometrial hyperplasia, there's proliferation of the endometrial glands. The primary risk factor for hyperplasia is overexposure to unopposed estrogen. We see this in patients who are perimenopausal, menopausal, or diabetic, or who have polycystic ovary syndrome. Endometrial hyperplasia in and of itself is benign, but it's a precursor to endometrial cancer. We discussed this in detail elsewhere. Synthetic progesterone, called progestin, can be provided to counteract the effects of estrogen overexposure. Endometriosis is present in more than 10% of women and often goes undiagnosed. It's an estrogen-dependent chronic inflammatory condition in which endometrium-like tissue grows outside of the uterus, resulting in adhesion and scar tissue in and around the pelvic organs. We show these lesions and adhesions on the uterine tube, ovary, bladder, colon, and in the rectouterine pouch. In more severe cases, lesions and adhesions have been found in the diaphragm, spinal cord, and elsewhere in the body. For more information on this, see our notes. Lesions and adhesions produce chronic pelvic, back, and abdominal pain that can be debilitating. The pain is often worse during menstruation, intercourse, defecation, and urination, and can depend on where the lesions are located. Unfortunately, it can interfere with ovulation and gamete transport and therefore cause infertility. We need a good index of suspicion for this because early diagnosis and treatment can help prevent formation of scars and adhesions that lead to lifelong problems, including infertility. Treatments include hormonal contraceptives and gonadotropin-releasing hormone agonists, which reduce the cyclical growth and shedding of lesions, and surgical removal of lesions, scar tissue, and adhesions in order to reduce the pain associated with these masses. Lastly, in this category, indicate adenomyosis. This is when endometrial tissue grows within the myometrium. Large lesions can cause myometrial hypertrophy, and it can cause dysmenorrhea and heavy menstrual bleeding. Treatment for this includes NSAIDs for pain management and hormonal therapies to limit endometrial tissue growth, and surgery to remove the adenomyomas. Now, endometritis, which is infection of the uterus that can affect all layers. It occurs when normal bacterial flora from the cervix and vagina are transferred to the uterus. It's the most common postpartum infection, particularly in C-sections when damaged uterine tissue facilitates bacterial colonization. Endometritis can also occur in sexually transmitted infections and pelvic inflammatory disease or following various procedures. Indicate that postpartum acute endometritis typically manifests roughly 1 to 3 days after delivery with fever, low abdominal pain, and purulent, foul-smelling vaginal discharge. Chronic forms of it can be asymptomatic or can cause abnormal uterine bleeding and infertility. From a management standpoint, we need to treat uterine infections with antibiotics to avoid sepsis and shock, and as a preventative measure, we should use antibiotics and vaginal cleaning prior to C-section. Next, indicate that Asherman syndrome is a rare condition characterized by intrauterine adhesions. They can form after dilatation and curettage, which is done to remove placental tissue postpartum or to remove pregnancy tissue after miscarriage or abortion. Asherman syndrome can also occur following endometrial infection with tuberculosis and other pathogens. Signs and symptoms depend on the severity of the adhesion formation, and they can include amenorrhea and impaired fertility. Treatment involves surgical removal of adhesions and prevention of reformation of the adhesions. Cervical and endometrial polyps are another type of growth that can impair reproductive function. We show pedunculated versions, but polyps can also be flat. Cervical and uterine polyps themselves are common and are usually benign and asymptomatic, but they do carry a higher malignancy risk in postmenopausal patients, and large polyps can cause abnormal uterine bleeding and infertility. Treatment options include hormonal contraceptives, which can shrink the polyps, or surgery to remove them. Finally, for completion, show that parauterine tube cysts are fluid-filled cysts that grow adjacent to the fallopian tubes. They're typically benign and asymptomatic, but larger lesions can cause feelings of pelvic pressure and pain and can facilitate adnexal torsion. In these cases, surgical removal of the cysts is necessary. This concludes our diagram.